A very good morning. Today we are going to talk about periodontal pocket. Okay. So as you all know, pocket is nothing but it is a pathologically deepened gingival sulcus. Okay. So it is a pathologically deepened gingival sulcus. So any sulcus which has gone beyond the limit or beyond the normal probing depth becomes pathology, and we are going to call that as pocket. Okay. So as we discussed earlier, what is PPD and CAL? So depending upon the attachment loss, depending upon the probing depth, we are going to determine whether the patient is having mild, moderate, or severe periodontitis. Okay. So you take a look at this. A small recap about CAL. Okay. So three scenarios. Okay. First scenario, the gingival margin coronal to CEJ. Okay. The second scenario, where the gingival margin is coronal to CEJ, but there is pocket formation. The third scenario, where the gingival margin is at the level of CEJ, and the fourth scenario, where the gingival margin is apical to the level of CEJ. Okay, see, I have explained all these in the basic tissues. So if you want, you can go and watch that. This is just a quick recap. Okay, so if the gingival margin is coronal to CEJ, okay, and the attachment is at the level of CEJ, then the cal will be 0. If the gingival margin is coronal to CEJ, and if there is a probing depth of more than 3 mm, say for example 6 mm, which means the patient is having pocket but there is no interproximal or interdental tissue loss, then what I'll do is I'll measure the probing depth and I will subtract it with the distance from the gingival margin to the CEJ. Okay, say for example if it's 2 mm, then my cal will be 4 mm. So you take a look at this situation. Gingival margin is at the level of CEJ. So this is called as hidden recession or progressive periodontitis. I don't know when it will stop. So in this case, I'm going to assume PPD equal to cal. If PPD is 2 mm, cal will also be 2 mm. You take a look at this case. This patient is having gingival recession, that is apical migration of the marginal gingiva below the level of CEJ, right? So in this case, what I'm going to do is I'm going to measure the distance from the CEJ to the gingival margin. Okay, CEJ to gingival margin, and I'm going to add it with the probing depth. Okay, so these are all the ways where you can calculate cal. Okay, so moving on to the classification of pocket. Okay, so any pocket, if you see, it can be apical to the crest of the bone, it can be coronal to the crest of the bone. Okay, so depending upon the position of the pocket to the bone crest, you can classify it as supra bony defect or an infra bony defect. Supra bony means the base of the pocket is above. Okay, the base of the pocket is above the crest. Infra bony means the base of the pocket is below the crest, which means the bone is above, the pocket is below the level of bone. So in those cases, the vertical bone loss will be infrabony, most commonly infrabony defects, and the horizontal bone loss will be suprabony. Okay, see, infrabony defects. Okay, one wall, two wall, three wall defects. Three wall defect is otherwise called as intrabony defect. How to remember? T, three wall defect. Okay, so just remember that three wall defect is intrabony defect. Infra bony defect is a general term which is used to describe one wall, two wall, and three wall defect. So in infra bony defect, the the pocket will be below the level of alveolar crest. In supra bony, it will be above the level of crest. Okay, now in relation to the surfaces involved, it can be a simple pocket. Okay, where there will be a pocket in only one direction. It can be a compound or it can be a spiral. Compound means more than two surfaces. Spiral means it twists and turn around the tooth. Okay, so this is a very basic classification. Okay, the classification of the bone defects was given by Goldman in 1958. Okay, the bone defects. Infra is a broad term, intra is a three-wall defect. Fine. Now, coming to pathogenesis of pocket formation. As discussed the earlier, the host response to the microbial. I'm just going to recap it again. Okay. So, whenever a bacteria enters the body, okay, the body detects and sends signals. So whenever the bacteria enters, there's going to be pathogen associated molecular pattern which is associated with the bacteria, and the body recognizes it, detects it with the help of toll-like receptor, and this toll-like receptor is going to synthesize pro-inflammatory cytokines. These pro-inflammatory cytokines are nothing but interleukin 1, interleukin 6, tumor necrosis factor alpha, and interleukin 8. Okay, so interleukin 1, interleukin 6, tumor necrosis factor alpha 8. So all these, if you see, they are going to bring the neutrophils to the site of infection. So they are going to cause inflammation, they are going to produce inflammation, they are going to bring this neutrophils. This is the first line of defense to the site of bacteria. Okay, so a detailed video of this has been taken in host response to the bacterial microbial invasion, so you can just watch it. This is a quick recap. So inflammation, the neutrophils, it comes out and it goes to the area by a process called chemotaxis, which is done by interleukin 8, and once it reaches the area, it is going to engulf the bacteria by phagocytosis. So what is the relationship between this and the pocket? Is very simple. These pro-inflammatory cytokines, they synthesize what is called as MMPs. Okay, these MMPs, they produce collagenases. So what do you mean by collagenase? As the name described, it is going to destroy the collagen, right? So it is going to break or destroy the collagen. It is going to break or destroy the collagen, that is going to result in pocket formation. That is going to result in pocket formation. Okay, see, since your junctional epithelium and the circular epithelium is semi-permeable, what it does is the bacteria, it directly enters into the connective tissue. So in the connective tissue, there is a fight. There's going to be destruction of collagen fibers, and there will be destruction of bacteria. So what will happen? There will be some destruction. So what happens is the junctional epithelium, it migrates apically. So the apical migration of the junctional epithelium takes place in pocket formation. Okay, now you just imagine that, see, look at here. Okay, so a bacteria which is present here, because of the semi permeable nature, it directly enters the connective tissue. Okay, it directly enters the connective tissue and it starts to resorb the bone. It fights against the connective tissue, so there is tissue loss. And what happens there? The junctional epithelium follows the architecture. Junctional epithelium follows the architecture. It migrates apically, and what will happen is, once the body has reached certain percentage of neutrophils, in this case, when 60% of neutrophils have migrated to the area of infection, the tissue is going to lose the cohesiveness. Tissue is going to lose the cohesiveness. So once the tissue loses the cohesiveness, that is going to result in detachment of the junctional epithelium from the tooth, right? Detachment of junctional epithelium from the tooth. This is the reason why the sulcus becomes deepened. So normally the junctional epithelium is attached to tooth at the level of CJ. What will happen is, because of the increased inflammation, there is going to be increased migration of neutrophils. It is like blowing a pouring water into the balloon. So once the balloon becomes big, it will not be in a proper shape, right? So what will happen is, because of the increased cohesiveness, imagine this is your tooth, okay? So this is your junctional epithelium is attached to your tooth, and because the neutrophils reaches 60%, the tissue loses the cohesiveness, so it slowly kind of detaches. And remember, it does not completely detach. Some part of the epithelium will be left in the tooth, some part of connective tissue will be left in the tooth, and it just breaks and it just moves away, right? Any break in the continuity of the epithelium is called as ulcer. So any break in the continuity of the epithelium is called as ulcer. So am I right in saying that in pocket there will be ulcerations? Yes, obviously. Why? Because the tissue loses cohesiveness, junctional epithelium detaches. Even though it detaches, there will be some portion of epithelium attached to the tooth, some portion of connective tissue will be attached to the tooth, some portion of plaque and calculus is present in the tooth. Okay, so in this way, I am going to split, or I am going to study pocket. What happens in the soft tissue wall, that is, this is the junction, this, say for example, this is a tooth, okay? This is a junction epithelium normally attached to tooth. Because of the cohesiveness, it splits, right? So I'm going to take this part as the soft tissue wall of the pocket, okay, and this part as the tooth wall. Okay, so what happens in the soft tissue wall and what happens in the tooth wall? Very simple, right? Okay, now what will happen in the soft tissue? As I told you, there will be atrophy of the epithelium, or destruction of epithelium by the bacteria. There will be ulcerations because there will be break in the continuity of the epithelium, and there will be increased inflammatory infiltrate because there's going to be fight between the bacteria and the host immune cells. Okay, so all these is going to take place. All these you can see in the histopathology of the soft tissue wall. Now if I take that soft tissue, and introduced in a scanning electron microscopy, same study, scanning electron microscopy, okay, if I take a piece of gingiva and introduce it into the scanning electron microscopy, then what I will say is, I will introduce an electron into the place. Okay, I will introduce an electron into the sulcus, and I'm going to study how the electrons pass and where all it passes, and with the help of that I'm going to see what is happening in the microtopography of the pocket wall, right? So what I will say is, there is going to be area of relative quiescence. So area of relative quiescence is, there will be small flattened cells, there will not be increased destruction, there will be small depressions, there will be small flattening of cells. Okay, in fact it is a quiet phase. Area of bacterial invasion, which means bacteria, they starts to invade. Okay, say for example P. gingivalis. Okay, so P. gingivalis, it starts to invade into the sulcus, it enters the epithelium, enters the connective tissue. So I can able to see an area of bacterial invasion where the bacteria tries to invade the epithelium and the connective tissue. What does the body do? Area of leukocyte infiltration, neutrophils, right? So what happens, what does the body do? Okay, you are coming, then I'm also coming. So there will be area of leukocyte invasion where there will be increased migration of neutrophils, and once these takes place, there is going to be area of ulcerations because there's going to be fight between the bacteria and the host cells, area of desquamation, and area of hemorrhage. So the area of hemorrhage is responsible for the bleeding, and area of ulcerations is because of the break in the continuity of the epithelium as it loses its cohesiveness, and there's going to be desquamation of the epithelium as the epithelium atrophies. So this is what I see when I introduce an electron into the sulcus, and I'm going to take the piece of the pocket affected gingiva and study it in a microscope. Okay, the microtopography of pocket wall. Next one is the surface topography of a pocket wall. We are talking about the soft tissue wall in the previous sections. Now we are going to talk about what will happen in the tooth surface, right? The tooth surface, you see the cementum covered with calculus, and then there's going to be zone of attached plaque. As I told, calculus will always have plaque over it. Zone of unattached plaque, and then there will be zone of or area of damaged or destroyed or ulcerated junctional epithelium, and also there will be connective tissue, especially gingival connective tissue. So this is what you see in the tooth surface. Soft tissue wall, tooth wall. Soft tissue wall, you see there's going to be atrophy, break in the epithelium, ulcerations, inflammatory infiltrate, and also when I introduce in electrons, I'm going to see area of relative quiescence, bacterial invasion, leukocyte invasion, area of ulcerations, desquamation, hemorrhage, and surface topography of your tooth. There will be cementum which is covered with calculus, and zone of attached plaque, unattached plaque, and then I can see the area of junctional epithelium and the gingival connective tissue fibers as they are not completely reflected. Okay, excellent. So cementum, what happens, it becomes irregular. Okay, it becomes irregular as they are invaded by various endotoxins, and so they become hypocalcified. Okay, so the aim is to recreate or to make the cementum a clean smooth one again. Clean smooth surface is the aim. Okay, so the cementum becomes hypocalcified because of the invasion of the endotoxins. So our aim should be to have a clean smooth surfaces. Now clinical signs, if you see, there will be bluish discolorations, there will be bleeding on probing, ulcerations, pain, pus. So these are all the few clinical signs which you see in a pocket patients. So bluish discoloration is mainly because of the stasis of blood vessels. Okay, and bluish will be seen in chronic inflammation. Okay, so during the stasis of blood vessels, as you can see, there is going to be transient vasoconstriction which is followed by persistent vasodilation. So in those cases I can see stasis of the blood vessels. That is why you get a bluish discoloration in the gingiva. Bleeding on probing, bleeding on probing is because of the various areas of hemorrhage because of the ulcerations, and also there is going to be first clinical sign of inflammation. So the first clinical sign of inflammation will be bleeding on probing. Okay, because there will be increased blood vessels. Okay, and also the ulceration is because of the atrophy of the epithelium, and pain is because of these ulcerations. The inner wall of the pocket will be extremely painful, and pus discharge, if there is inflammation, there will be presence of exudate. Okay, and one more thing I would like to tell you is sometimes the pocket wall might look fibrotic, which means the walls will look pale. Okay, but only outside it will look pale, or outside the healing has taken place, but inside there will be ulcerations and pocket formation which is going on happening. So when I see a patient with pale pink gingiva, but I see a bone loss radiographically, it doesn't mean the patient is not having disease. Patient is having disease, it is healing in the outer aspect, but the inner aspect, it has pocket. There is a destruction which is continuously happening in the patient. Okay, so these are all the few things about pocket. So pocket is a very important topic. The thing we should know about pocket is what happens in soft tissue wall, what happens in the histopathology and microtopography, that is same study, and what happens in the tooth wall, and what is the classification of pocket, Goldman Cogan, what is intra bony defect, what is infra bony defects, and what is the pathogenesis of pocket formation. With this you can answer any MCQ pertaining to pocket. And remember, intra is 3-wall defect, infra is the general term which has 1-wall, 2-wall and 3-wall defects. Okay, so thank you so much for watching this video. Have a great day. Thank you.